Welcome to this first Women's Sexual and Reproductive Health Noon Seminar of the season. And today we're going to be presented some recent work that we did in the department about the indirect effects of COVID pandemic on women's sexual and reproductive health in low-income settings. This is a story of resilience of women and health systems. So just as an introduction, my name is Moreau, and I'm an associate professor in the department. And today I have the pleasure of having three young and talented PFRH faculty who are joining me. Linnea Zimmerman, who is an assistant professor, Celia Karp and Shannon Wood, who are both research scientists. So all three happen to be recent graduates from our own and very own PhD program. They're now involved in a number of research projects, including PMA. PMA stands for Performance Monitoring for Action, and it's a landmark program that was launched by the Gates Institute in 2012. And Linnea actually leads the PMA project in Ethiopia. So just a very small side note for our fellow students who are in the audience, and I know you're working hard to fulfill our program requirements. And I want you to notice the presentation today is a great illustration of why your efforts matter and how they will pay off. As you'll hear, Linnea, Celia, and Shannon are making significant and timely contributions to our knowledge about the indirect effects of COVID on women's health at a time when public health has never been so critical. So next slide. The stakes are high, as you're going to see in the next, I'm not seeing Thanks, Celia. So the stakes are really high, as illustrated in the paper headlines you're seeing on the screen, warning about the indirect implications of the pandemic on women's sexual and reproductive health and rights. Next slide. So today, our purpose is to share some recent work that is destined to assess the early implications of the COVID pandemic on women's need, access, and use of family planning in low resource settings. Threats to women's health are real. They're linked to the redistribution of healthcare resources towards COVID patients, but also coupled with public health measures to curb transmission. And lockdowns have constrained mobility, but at the same time, they've heightened some vulnerabilities. We think of economic vulnerabilities, of course, but also of safety concerns, as we've heard around the world, rising reports of violence against women. In low middle income settings, we estimate that about 700 million women access family planning services for modern contraception, and 90 million deliver or terminate a pregnancy in health facilities. And the early projections have estimated that assuming service disruption would affect 10% of women in need of these services, we would see 15 million additional unintended pregnancy, leading to 28,000 additional maternal deaths as a result of COVID disruptions. And these concerns are ever so great in sub-Saharan Africa, given fragile economies, weak health care systems, but also high levels of unsatisfied demand for contraception, pre-existing unsatisfied demand, as well as high rates of unintended pregnancies. Next slide. And so while we know through editorials and commentaries that we're quick to signal the alarm, there's actually been little empirical evidence to understand the indirect impact of COVID on women's health, including their need for, their access, and their use of family planning. So today there is a number of research as well as vital statistics, mostly in high-income settings, suggesting that women are delaying childbearing, and that results in a drop in fertility rates. But we don't have much data that relates to low and middle income country settings. Likewise, there have been a number of reports from international organizations, NGOs, the UNFPA, that have reported on disruptions in services with raising concerns about facility closures or commodity stockouts. There's also evidence from case studies in specific facility reporting on disruptions of services, or larger studies such as in Mozambique, using administrative data suggesting modest short-term drop in service provision and utilization, but that was followed actually by a relatively rapid rebound. So together, these studies provide an incomplete and potentially biased picture of the indirect consequences of COVID on women's reproductive health decisions, needs, and access. So next slide. This leads me to the PMA COVID study that was designed, among other objectives, to explore the three following questions. How has the pandemic affected women's need for family planning? And more specifically, how has it affected their fertility intentions? Second, how has the pandemic affected family planning behaviors in terms of prevalence, but also method mix? And finally, how has the pandemic affected the provision of family planning services? Next slide. And so this study takes advantage of PMA's data collection platform that's designed to conduct nationally or regionally representative surveys that are both low cost, rapid turnaround surveys, and that's because we use a cadre of trained resident interviewers using smartphones to collect data, and they produce key family planning and reproductive health indicators in a number of countries in low resource settings. In 2019, PMA shifted to a longitudinal design that was launched in 4 localities just before the start of COVID. Those panels include a female-based panel, as well as a facility-based panel. And both panels are linked because the facility-based panel takes place in the same localities as the female panel. So data collected annually, starting with phase 1, which corresponds to baseline, followed by phase 2 in year 2, and then phase 3 and year 3. And actually we're between phase 2 and 3. So women from phase 1 are followed up until phase 3. But in addition, in phase 2 and 3, we have replacement households to compensate for attrition and maintain a representative cross-sectional survey each year. In addition to this panel design, PMA included an additional round of female data collection between rounds or phases 1 and 2. And that took place between May and July of 2020. And the specific purpose was to explore the early impact of COVID. So I don't have time to go into the details of the PMA COVID survey, but I'm happy to take any questions at the end around that specific survey. The female data we will be presenting today are from 4 of the settings that are represented here in the purple that started their panels before COVID pandemic started. And so these are the 4 settings where we also carried out the female COVID specific survey. The facility-based survey also includes sites that actually started their panels during the pandemic. So those also include Niger, Rajasthan, and Uganda. While PMA surveys are generally conducted face-to-face, the COVID-specific survey was a phone survey. And so this has implications as a significant proportion of women were excluded from the COVID survey because either they didn't agree to be followed up, but mostly because they didn't own a phone or they didn't respond to the phone call. And so this phenomenon is not trivial, as you can see represented on the graph here. as ultimately between 41 to 68% of women of phase 1 actually participated in the COVID phone survey. So obviously that might introduce some selection bias, and to account for it, we weighted the COVID survey data to account both for the selectivity of owning a phone, and we further weighted the data to account for non-response of phone owners. So all the results that will be presented all applied these weights in addition to the original PMA sampling weights to account for this specific selection bias. The phase 2 data that we will also be presenting don't have the same selectivity issues, as we're using phase 2 cross-sectional data, and they include phase 1 women plus the replacement households, and therefore are representative of women of reproductive age at that time. Before I leave it off to my colleagues to share their results, I just want to comment on the economic impact of the pandemic in these low resource settings. And this is exemplified in this slide with the 2 graphs. So on the right, actually on the left, the graph represents income loss or household income loss that is either partial or complete. And this is represented by household wealth tertiles and by site. On the graph on the right, you have featured food insecurity that's featured in light green. And again, it's presented by household wealth tertiles and by setting. So what these graphs show is that a vast majority of women experienced household income loss, generally partial, that's kind of in the intermediate blue color, but sometimes even complete income loss, as you can see in the light blue portion of the bars. And that's specifically true, for instance, in Kinshasa, which is really at the far left of your graph. Likewise, there's a significant proportion of women who experience food insecurity, and that's even more true for women who live in the poorest households, for instance, in Kinshasa on the left or Lagos on the right of your graph. So these data are relevant to our conversation and across the presentations, as economic circumstances are important drivers of fertility decisions and contraceptive use. And so now I will pass the baton to Linnea, who will discuss how the pandemic has affected women's fertility intentions.
Thank you, Caroline. I think we can skip to the next slide. So the impetus for this analysis that Caroline just went through in great detail was really based on digging into this assumption that COVID-19 would lead to more women wanting to prevent pregnancy. So most of the evidence that events like epidemics or economic uncertainty, the assumption is usually that this would lead women and their partners to want to delay pregnancy until there's more stability introduced into the general system. But almost the vast majority of that research has really been from high-income countries. And what generally limited research there is that has focused in low-income countries has found that actually amongst the most vulnerable women, in fact, situations of economic uncertainty or related to epidemics may actually accelerate their fertility desires to offset that uncertainty and try and reinstitute some form of stability and control into the environment. So we really wanted to look at first at the population level. Do we see that there's population level change in reported fertility intentions? And that's across the 5 settings that Caroline just mentioned. And then also at the individual level, we wanted to look at what are the predictors of change. So which women are staying stable in their fertility intentions and which women are changing their fertility intentions and in what direction. So in that case, we looked just at Kenya because that's where we had the largest sample size. So this is the framework that we use to guide our thinking on the analysis. And the COVID-19 pandemic had obvious implications on a global scale, on a social scale, community scale, individual, everyone was impacted by COVID and at multiple levels. And so on the left, we just see that the COVID pandemic has really affected community factors all the way down to individual factors. But not just the pandemic itself, but also the response to the pandemic. So social response to pandemic could include school closures. It could and did include mass restrictions on movement, which would then introduce uncertainty into economics. So for example, in Kenya, where women may be relying on market-based economics to support their households, with restrictions on movement, with cancellations of markets, that introduces quite a bit of economic insecurity into the household. There's then also individual response to the pandemic. So people may or may not be able to wear masks, to stay in their homes, to get vaccines. There's the individual ability of people to actually respond to the pandemic and to the social restrictions that are in place. And so that too introduces some level of economic or health insecurity, that people are constantly balancing all of these different responses and different introductions and weighing in their mind how secure are they in their economics and in their health. And we assume that level of security would have some implications for fertility intentions, whether people want to have children and when. And then eventually whether or not those fertility intentions actually relate to realized fertility. And that's very much the family planning piece that Shannon and Celia will discuss later. So I'm going to very briefly present results from two analyses. And the first was just population level, as I mentioned. So this was just looking at across the 5 sites that Caroline mentioned before, what percentage of women stated that they wanted a child within 1 year, what percent stated they wanted a child, but they wanted to wait for more than 1 year, and what percent stated that they don't want any more children. And so we asked these same questions at baseline, which was generally around November to January prior to COVID. And then we asked the questions again during the COVID survey. And so we're just looking at across these populations, what does this distribution look like? The second analysis that we did was the individual level. So here we actually looked at individual reports of fertility intentions, and did women report using these same measures of wanting a child within a year, over a year, or no more. Did they report consistently? For women who didn't report consistently, and we'll go into these measures in a little more detail, did they accelerate their childbearing desires? Did they delay their childbearing desires? And here we actually were able to include a number of controls, and these are very relevant to what Caroline just mentioned, where we included whether or not the women lived in households that had partial or complete income loss, whether they were experiencing more food insecurity than prior to the pandemic, and whether they self-reported an ability to social distance. And here it's just important to note that this was what women said, if they were actually able to comply with social distancing measures. We couldn't confirm that they actually were. And then we adjusted for sort of standard socioeconomic variables, residence, education, parity, and wealth. And we'll get into this piece here, but we had to stratify by baseline intentions to identify who was changing and who was consistent. So just at the population level, what we saw is that there were significant declines, and just to note, this is actually the analysis of 2 years. So these are women who say they want a child in less than 2 years, want in more than 2 years, or want no more. The results were extremely consistent when we looked at the percent that wanted in that wanted in 1 year. But on the whole, we saw that there were actually significant declines in the percent of women who wanted no more children. So we did not see any shift towards women saying, because of COVID-19, I want to finish childbearing. Maybe I wanted another child before, I don't want it now. We saw no evidence that that was the case. We did see significant increases in the percentage of women who wanted to delay childbearing. So there were cases, there were in Burkina Faso, Kenya, and Lagos, a higher percentage of women who said, I want another child, but I want to delay for 2 years. And we didn't see that that was the case in Kinshasa or Kano, Nigeria. And as I said, these results were very similar when we looked at the 1-year level. So it did look like there was some shift away from saying, I don't want any more children, to I do want a child, but I just want to wait. So at the individual level, what we did is looked first at the question of, do you, at baseline, we asked, do you want a or any more children? And then for women who said, there were women who say, yes, they want at least one more child, or there were women who would say, no, I want no more children. So that's we defined as quantum. This was just related to the general number of children. And women were defined as either stable, if they said at both time points, yes, I want another child. Or they said at both time points, no, I don't want another child. We defined women as antenatal if they said at baseline, yes, I would like another child. And they said at follow-up, I don't want another child. So they switched to not wanting any more children. And then we defined women as pronatal if they said at baseline, I don't want any more children. And at follow-up, they said, I do want another child. So that was just related to not necessarily the exact number, but just do you want another child at all? But we also looked at tempo. And here we were looking at whether or not women said that they wanted a child sooner or they wanted a child later. So looking at, again, baseline, we first identified women who said, I want another child within a year, compared to women who said that they want another child, but in more than 1 year. So women were stable if they said essentially the same timeline at both points. And then we identified women as decelerators. So they slowed their fertility intentions. If they wanted a child in 1 year at baseline, and then, they wanted a child at less than 1 year in baseline, and they wanted a child in more than 1 year at follow-up, and accelerators if they were the opposite. So they wanted a child in more than 1 year at baseline, and they wanted a child in less than 1 year at follow-up. There's a lot of outcomes. Had to walk through those so that you can see why these slides make sense. So first, if you just look at the percentage of women who just were consistent, the vast majority of women at both time points in Kenya were consistent. So this dark purple is just in quantum, the number of women who at both time points said they want more children. The purple is the number of women who said they don't want more children. And blue is the number that switched. So the slightly darker blue is the percent that went from not wanting a child to wanting a child. And the light blue is the percent that went from wanting a child to not wanting a child. The same is with the green. So here you can see that 85% of women were very consistent in what they were saying. So 75% of women were consistent in saying they wanted a child in more than 1 year at both time points. Only 8% of women accelerated their fertility intentions, and 8% decelerated their intentions. So overall, within a 6-month period, most women, very consistent. When we actually looked to see what might identify, what characteristics might be associated with women switching their intentions, so moving from pronatal or antenatal, we saw that women of higher parity were significantly less likely to adopt pronatal and more likely to adopt antenatal intentions. So here on this slide, where it says parity 3 to 4, women who, so compared to women who were 0 to 2, who had 0 to 2 children, women who had 3 to 4 children or 5+ children were significantly less likely to say that they wanted another child. And then they were significantly more likely to say that they did not want another child. And that makes sense, that women who are of higher parity are perhaps more likely to say that they have finished their childbearing intentions than women of low parity. COVID-19 is hopefully a passing event, and it's something that women can sort of wait out and decide that they want another child later. And we didn't see any evidence that any of the COVID-19 variables were related to this decision to change the number of children that you're interested in having. But we did see that COVID-19 variables were related to the timing of wanting a child. So we saw that when we were looking at food insecurity, women were able to report food insecurity in three different ways. They didn't have food insecurity ever. They didn't have it before the pandemic, and they didn't have it after. Or they did have food insecurity before the pandemic, and they had food insecurity after, but it had remained the same. Or they could say that food insecurity increased. So they had food insecurity before, and it had gotten worse. And what we saw, the only variable that was strongly significantly related was that for those women who had chronic food insecurity, so those women who had food insecurity before, they had food insecurity after, those women were the most likely to say that they wanted to accelerate childbearing. And while we have some evidence of marginally significant relationships and other variables, this was the only one that was really strongly related. And so in this case, it seemed like those women who are most vulnerable are actually not wanting to delay their fertility intentions, but wanting to accelerate them. So just in conclusion, on the whole, we saw that there was little desire to change the number of children. And though there were some shifts, it seems like those shifts were generally towards delaying. But these weren't large scale numbers. I can't go back to the slide now, and I didn't really highlight it, but these were really fairly small percentages. Though they were statistically significant, we didn't see huge shifts towards wanting to delay childbearing. We saw that on the whole, COVID-19 had almost no impact on the number of children that women desired, but it did affect timing. And so particularly amongst the poorest women, COVID-19 seemed to indicate that women wanted children sooner. And the insecurity introduced by the early months of the COVID pandemic did not lead to widespread changes in fertility intentions, and the most vulnerable women accelerated those fertility intentions in response to the pandemic. So I'm happy to take any questions in the chat, but I'll hand it over to Shannon to talk about how the pandemic affected contraception.
Thanks so much, Linnea, for contextualizing everything that's happening with fertility intentions, because that's certainly a piece of need for contraception. So I'm going to present on some of our results at the population level surrounding women's need for and use of contraception among women in need. And then I'm going to pass it off to Celia to describe some of those individual level changes and getting more into contraceptive dynamics. So here we are focusing on those first 4 countries that had the baseline and the COVID surveys. And we're looking at 2 outcomes. The first of which is need for contraception. So that's defined as ever having sexual intercourse, were married or in union, not pregnant or infertile, and did not plan to give birth in the next 12 months. Of note, we did not have sexual activity within the COVID survey, so that is why our variable for need is slightly different than common definitions. And then we also look at use of contraception among women in need. So need is the denominator for that. And we look at this overall per setting, split urban and rural for each site, and then across a number of different socio-demographic and COVID-19 related experiences. Given timing today, we'll only present on 2 of those, but I encourage you to look at all of them outlined in the paper that we'll give you the link to at the end. And so we compare point estimates between these baseline and COVID surveys for each of our outcomes, and then again stratified across. And you'll see these presented as a percentage point change. And we calculate the confidence intervals, and then we look at the difference in the confidence intervals to see whether or not those are significant. Then we assess trends across 4 survey rounds. So we actually took the 2 rounds preceding our baseline survey to see whether or not these trends were taking place beforehand, or if this was something new that we were seeing. And then also something that we'll be presenting on today that we haven't presented on before is what's happening in the longer term. So we have the phase 1 survey, the COVID survey, and then we'll also add in the phase 2 survey to see if what we're seeing at COVID has been sustained longer term. Next slide. Oh. Perfect. So our first outcome was need for contraception. So we'll actually start with this change over time and look at these previous rounds. So as you can see from our our 2017, 2018 pre-COVID and COVID survey split by urban on the left, rural on the right. The only setting that we actually saw a significant change in need for contraception was in Lagos, Nigeria. So overall, no significant changes in need. Again, overall, this is not stratified by specific characteristics. Next slide, thanks. Then we look at changes in use of contraception among women in need. And so here we do see, we have a little bit of a different story. So on the left, you can see that there are changes among urban women in Kenya, quite small. But then in both of our rural geographies, both Burkina Faso and in Kenya, you do see some sharp increases between the pre-COVID and the COVID surveys. And so a lot of people were really interested in whether or not these increases were real. And so this is why it's super important to then contextualize this with our phase 2 survey, which we'll get into, but some previous work from a colleague of ours, Ava Greenleaf, actually, who did her PhD in the department, really pointed out survey modalities. So as Caroline alluded to, our phase 1 survey was face-to-face, but our COVID survey was phone. And so we've waited for attrition and all of these other pieces, but we couldn't look really into survey modality. And so we didn't know if there were biases that were being introduced in this. So this is why the big question was, okay, is this being sustained over time? Are these real increases that we're seeing? Okay, so that's the big question, but I'm going to dig into some of these sociodemographic stratifiers first. So think of this a bit as a stoplight. So the orange are areas that we would expect to see significant increases in unintended pregnancy. So kind of the warning signs. And this is split by parity. So on this top row, you can see that among nulliparous women across all of our settings, there were significant increases in need. So this is kind of a warning sign that we highlight for policymakers. We need to look at this. In urban Burkina Faso and in rural Kenya, that was also accompanied with significant increases in contraceptive use. So not as troublesome, but in other sites where we don't see these significant increases, this is something to continue to monitor over time. And then just to say that the increases in contraceptive use were really concentrated among Paris women in other settings that you can see in the darker green squares down below. Thanks, Celia. Then we also break this down by COVID-related economic losses. And we hypothesized initially that we would see significant increases in contraceptive use really among those with partial and complete COVID-related economic losses. And here we see that is the case somewhat. In Burkina Faso and in settings in Kenya, it is concentrated among those with partial related losses, but in rural Kenya, we do see this across all women. Next slide. Okay, so here's the big question that everybody has, and that is what is happening later in COVID? And so I don't know how well you can all see this, but largely across all settings, there have been increases in use of contraception between that pre-COVID and later COVID survey. In some settings, there are slight decreases between the COVID and later COVID. So that might be an issue of survey modality. That's something that we need to dig into further. But overall, if we look at, the larger line between pre-COVID and later COVID, it is showing a general upward trend. So that is telling us that what we're seeing in terms of increases in use has occurred across these settings. And again, happy to field any of these questions later on, and additional stratified analyses are presented in the main paper. And so at this point, I will hand it off to Celia to go through some of these individual level changes so that we can see more of what's happening with women's contraceptive dynamics.
Thanks, Shannon. So as Shannon mentioned, this analysis actually focused on understanding women's contraceptive dynamics during COVID. So that's whether they adopted, discontinued, continued, never used, or switched methods during those early months of the pandemic. So we applied the same definition to our sample of women to consider women who are at risk of unintended pregnancy before and during COVID-19. And in this case, we're actually using linked survey data. So that's linking the data between phase 1 and the COVID survey. So our sample included about 1,100 women in Burkina and 2,800 women in Kenya. And then in terms of the approach to our analysis, we actually first compared women's reported contraceptive use, any method, and then by method effectiveness categories as represented in that graph here, or the diagram, both before and during COVID-19. And second, we ran multivariable logistic regression models to estimate women's odds of adopting, discontinuing, or switching to more or less effective contraception among women who we considered to be eligible for each of those outcomes. And then third, we assessed the proportion of women who reported COVID-related reasons for non-use using descriptive statistics. And all of these analyses, like the other ones presented today, also use the same kind of weighting procedures. So jumping right into the results, because now you're familiar with the data, we found that most women did not change their contraceptive status during the early months of the pandemic. And so here you see results from Burkina Faso on the left and Kenya on the right. And the green bars reflect among all women in our sample, the proportion who adopted, discontinued, continued, or never used contraception based on their responses to the two surveys before and during COVID-19. So the categories that are highlighted in those black boxes highlight women who either never used contraception or continued to use their methods. And that is, they did not change their overall contraceptive status during the early months of the pandemic. So next, looking at these proportions by women's baseline contraceptive status, and so that's whether or not they were using a method at baseline, we found that the majority of women here who were using contraception before the pandemic remained contraceptive users during the early stages of the pandemic, again, as highlighted on in those black boxes on the right side for each country. And then in Burkina Faso, we also found that the majority of non-users remained non-users during the pandemic. We also found that roughly 5 to 6% of women discontinued the method that they were using during COVID-19. And this was the outcome that we were really interested in because of all the concern that Caroline highlighted in the beginning of this presentation. And then finally, we found that 1/4 of women in Burkina Faso and 13% of women in Kenya actually adopted a method during the pandemic, which was highlighting a little bit of the unexpected outcomes that Shannon started to talk about at the population level. So now in terms of switching methods, among women who were using contraception before and during COVID-19, so that's women who are in the orange bar, we found that 5 to 7% transitioned to using less effective methods. And the vast majority of consistent contraceptive users, that's women who were using contraception at baseline and at follow-up, were also using methods that were as or more effective than their pre-pandemic contraceptive method. And remember, we were able to do that because we actually looked at the method types that were used at each time point. And finally, we found that the largest changes in switching were among women who were using the least effective contraceptive methods before the pandemic hit. So that those were methods like condoms, other barrier methods, or traditional methods. And a greater proportion of these women switched to adopting more effective contraception relative to other method users. So then when we investigated kind of who changed their contraceptive practices, and these are the results highlighted just in text because there were 4 different multivariate models used. It would just be a lot of tables and numbers, so we simplified it for you. But we found that women who were very concerned about becoming infected with COVID-19 were less likely to adopt contraception or switch to more effective methods in Burkina, but they were actually more likely to adopt contraception in Kenya during this time. We also found that those who experienced partial household income loss during COVID-19 were more likely to adopt or switch to a more effective method in Burkina, and that women who were experiencing heightened food insecurity due to the pandemic were also more likely to adopt contraception and less likely to discontinue their method if they were already using in Burkina specifically. And so that really highlights COVID-19's impact on women's reproductive health behaviors, as Linnea also started to mention in the fertility intentions piece. So then in terms of the reported reasons for not using contraception among these women who indicated a desire to prevent pregnancy both before and during the pandemic, we found that fear of infection at health facilities was a key reason for non-use, especially in Kenya, where almost 10% of non-users reported COVID-19 related fear of infection at the facility. So in this final segment of the presentation, we're going to switch to addressing our third research question, which focuses on how the pandemic has affected the provision of contraceptive services at the facility level. So this analysis leveraged data that was collected as part of PMA's service delivery point or facility questionnaire, facility survey that Caroline talked about in the beginning. So data were collected before the pandemic in some countries and then during the pandemic in all countries, providing longitudinal data to explore some changes in services during COVID-19. And so the facility survey relies on responses from a facility in charge, and that's usually the lead in the facility or someone who's specific to family planning services, depending on the component of the survey. And it also includes an inventory of related family planning supplies and commodities. So our sample included 2,437 public and private facilities that offered family planning services across 6 countries. And our key outcomes were reported disruptions to family planning, for example, service availability, contraceptive method supplies, changes in demand and availability of providers, which we looked at in terms of descriptive statistics and described those disruptions or changes to services. And then our second outcome highlighted in that blue box were the observed disruptions or declines in family planning services, such as fewer days that services were offered when we compare the 2 time points, an increase in stock out of contraceptive supplies, and a decrease in demand for services, which we assessed again through a comparison of the differences between the data we collected before COVID and then the data we collected during COVID, only in those first 4 countries for which we had that comparison available. Oops, this is getting ahead of me. Okay, so provide you with a quick overview of the results. Reported disruptions were common, as we can see here, highest in Rajasthan, which is indicated there in that pale green color, and lowest in Burkina Faso and Côte d'Ivoire. And many facilities experience reduced operational hours, which you can see all the different categories are along the x-axis there. And many facilities reported being unable to maintain client records specific to family planning. And they also experienced significant changes to the availability of providers, some being reassigned to COVID-specific units and others that were just not showing up to the facility as needed. So we also found large declines in large reported declines in family planning clients, which were greatest in Rajasthan, as you can see in the blue and green sections of the bar there, followed by Nigeria and Uganda. And then when we looked at observed declines in the availability of services, declines were most common in the DRC, where we found that about 1/4 of facilities were actually open for fewer days at the COVID follow-up than they were at baseline. And while the lower demand for family planning services was common across geographies. And so that's shown there by the 30 to 40% of facilities that report lower monthly family planning client volumes, again, comparing the pre-COVID data to the data collected during the pandemic. So additional analyses are actually exploring changes in the availability of contraceptive supplies and commodities, as well as the frequency of stockouts and if that increased during the pandemic. So we will get into that in future analyses and hopefully in future publications, so stay tuned. And now I'll hand it back over to Caroline to share some conclusions and considerations for this research moving forward.
Thank you, Celia. And I'll just take a minute or two to kind of summarize some of our results. Our PMA results suggest that COVID has had actually little impact on women's need for family planning. And if it did, it in some ways accelerates the timeline for some women who experienced food insecurity. We also found surprising results in the form of increases in use of contraceptive prevalence in Burkina and Kenya that might not be fully sustained over time, but anyhow, after a year of COVID, these levels have not dropped to below pre-COVID levels. I think Celia has just indicated through her individual level analysis that a majority of women did not change contraceptive status, which is consistent with the population level results. And more women adopted methods than discontinued or switched to less effective methods in Kenya and Burkina specifically. And finally, while perceptions of service disruptions were widespread, some indication leads to the idea that observed disruptions may be less pronounced. So altogether, we conclude that women and health systems have been resilient in the early stages of COVID. And I would suggest that the last decade of renewed investments has greatly contributed to the success. However, we also want to raise a word of caution for several reasons. Number one, international investments seem to shift away from family planning, and I'll give you the example of the UK or US investments as kind of potentially declining in this area. And second, the pandemic is still ongoing, and specifically in low resource settings with low levels of vaccination. Those economies continue to suffer, which affects women's ability to afford sexual and reproductive health services. So these challenges call for renewed advocacy and monitoring efforts to ensuring accountability from the international to the local levels. And this is to avoid disparities in women's health between the global north and the global south. And I'd like to end this presentation in the next slide by acknowledging all the many peoples around the world who have, and some of them are also in this audience, who have contributed to this work. And I'll start with our in-country PMA PIs who are featured here on the slides. Also recognizing the role of Phil Inglovitz and Elizabeth Gummerson, who lead the PMA project. All of the project officers, the programmers, the data managers, and the administrators who carry out the PMA operations. The PMA project is hosted in the Gates Institute in collaboration with JPIGO and is funded by the Bill and Melinda Gates Foundation. So thank you all. And now we can open it up for questions. And I'm seeing some questions in the chat, and I saw a number of people have responded as we were moving forward. Maybe we can pick up on questions that relate to violence. Linnea indicated that the violence questions were not included in the phone survey related to COVID. But there is another project related to PMA and focused on young adolescents. We didn't have time to present it, but has a lot of data on violence. And maybe Shannon and I can call you and to comment on those specific results in Nairobi, Kenya.
Thanks, Caroline. Before I get into those results, I would actually speak first to the overall PMA survey within phase 2, the round that was collected last, in most contexts, I guess, last fall. We did include a PMA GBV mini module in Burkina Faso and in Kenya, and that was at direct request of the governments and in-country stakeholders that were really worried about increases in violence given COVID-19. And so we had questions specific to physical, sexual, and emotional violence, then also looking at frequency, and then whether or not the violence frequency had increased, decreased, or remained unchanged since COVID restrictions. And actually we saw that in the majority of contexts across both of them, and particularly in Burkina, that it had decreased or remained relatively unchanged. So the increases that we thought that we'd see, we really aren't seeing, but that certainly doesn't mean that it's something that we shouldn't keep looking at and considering, especially as, exactly as you were just talking about, as the pandemic continues to evolve. Specific to the adolescent study in Nairobi, Kenya, we saw something similar in that we weren't seeing increases, but across the board, we actually had 3 time points there. And so pre-COVID, mid-COVID, and later COVID, we saw that young women were, 17% of young women experienced physical or sexual violence across all 3 time points. So it was very stable, but also that's quite a large number for past year physical or sexual violence, or within that time period, physical or sexual violence. So again, something to continue to monitor and think about. I saw Charvan's question. I think it was specific to relating it to fertility intentions. We weren't able to do that yet for this, but certainly something to think about, and especially as other countries move forward, thinking about some of the violence data collection. So thanks for raising that.
Thanks, Shannon. And just indicating to everyone, you can feel free to unmute your mic and ask questions. So please jump in. And also, I forgot to tell you that there's a lot of resources on the PMA websites. A number of these results have been published in the BMJ, Sexual and Reproductive Health, and the Lancet. We have just a new publication in Pulp Plus Global Health from the Ethiopia project. So we invite you to look at all of those publications. And I'm seeing a question from Dana to Celia about contraceptive dynamics and how the results between pre-COVID and COVID actually might reflect some dynamics that we would see outside of the pandemic.
Yeah, thanks, Caroline. Thanks, Dana, for the question. I was typing back to you, but Caroline beat me to it. So I think that's a really important point to raise as we think about what we're seeing and if it's really that different from what we would expect during this time. I think that, yes, you raise a good point that there are expected changes to occur during a 6-month period regardless, and we didn't have a control, kind of as you mentioned, to look at if those compare, to compare if those changes were happening in a different time period. And that's because of the newly longitudinal format of the data. But I think that the key piece that we were interested in is how those COVID-related factors that we captured were influencing the changes that we were seeing. So that's kind of why we focus on it. And the questions weren't specific to if they adopted or discontinued due to the pandemic. In the ways that some of the fertility intentions were asked kind of directly like that, if the pandemic affected fertility intentions. So we were actually just comparing the differences between the 2 time points. And then beyond kind of looking at those variables that we talked about for food insecurity or household income loss that were specific to COVID, we also were able to look at that proportion of people who were not using contraception, but reported COVID-related reasons for non-use. So that's kind of how we're, disentangling what we're seeing and trying to understand it in the context of COVID, but definitely that these changes happen with or without a pandemic, and that's important to note. So thank you. I also see Andrea's question. Maybe I'll just address that really quickly while I'm still on. Andrea, thanks so much for the question about the FP stockouts. So those were, there was a measure of perceived changes, and that's what we started to report. And then the main measure of interest that it sounds like you're getting at is the difference between observed stocks and reported recent stockouts, both before and during COVID. And that piece we're still exploring just because there are so many different ways that you can present that data. But it is actually a longitudinal analysis within those facilities to look at recent FP supplies and stockouts before and during COVID. So that will be coming soon and presented at USSP. So more on that.
Thank you, Celia. I don't think I'm seeing any other question. There was a question about STIs, but we don't collect that information. And also STIs are highly underreported. Many of them are asymptomatic. So we would need to do STI testing, but that's a very relevant question, especially in that region. And I'm seeing a question from Anita. The price of PPEs went up since COVID. Did the price of contraception change? And if so, did this change affect the use of contraceptives among women from the sample? That's a great question. I think it depends on context, and I will just respond. I'll start responding for Burkina Faso that actually implemented a law to provide free access to contraception pretty much close to the period of the pandemic, which might be also explaining some of the rise in contraceptive use in Burkina Faso. I can't speak to the other countries that I don't know as much, but maybe other people can interject.
So I welcome any colleagues who are on this call from any of these countries to please jump in and respond. But one thing I will say in response to Anita's question about changing contraceptive prices is that because we saw such significant declines in some, at least in some regard, and in some context for the number of family planning clients, what we still don't know about is if there weren't tremendously, dramatic reductions in stocks because people also weren't going to facilities. So facilities didn't necessarily have to maintain the stocks that they normally had because their client load was changing. So we're still kind of looking at those pieces and how they relate. But you raise an important point about maybe considering, the cost of these things in the future. So thanks for that.
I can speak a little bit to that too, again, with our Nairobi youth data. So we have qualitative data for that study, and a lot of youth, particularly young men, spoke about closures to youth-friendly centers, and so inability to access condoms that were, before the pandemic, generally provided at these centers free. And so back to Celia's piece about increases in method effectiveness, and especially switching from those coital dependent methods, that could be in part because those methods were no longer freely available. So thinking about that, but I don't have data on specific prices, but free provision could certainly drive that. I think that there's a hand raised.
Yeah, Yola, your hand is up. You have the mic.
Oh, hi, thank you so much. This is really interesting research. I was just wondering, intuitively, I would think because of COVID, more people would be, even if they're going through food insecurity and stuff, and such a world of really no stability. I would think intuitively that the family planning would increase, but but in looking at the research, there is there is a decrease. And I was just wondering, do you think cultural aspects have impacted your research, where you see that there is food insecurity and COVID is still happening, but women still want to have children? Do you think it's also cultural aspect that affects that also?
Linnea, do you want to speak to the fertility intentions piece that's relevant?
Sure. So certainly I would say culture always impacts everything that we're looking at. So certainly just the cultural relevance of having children and the importance of having children, I think in general is much higher in sub-Saharan Africa and in India as well. I think in many places, and where the research, we didn't necessarily explore this, but the research that has been done has really shown that particularly in places affected by HIV, which is very different, very, very different, but still where there are places where the epidemic is very strong, and where women get a lot of their sort of importance and sort of cachet within their community from having children. Women get more stature from having children, that it is a very important response to the pandemic, that women can actually really get a lot of community support and in turn also be seen as higher, just higher status within their community. So I think that sort of aspect of culture has a lot to do with it. I think too that that there's COVID is very much an unknown. We have no idea how long it's going to last, how severe it's going to be. And I think how people respond to that, both immediately and as Dana pointed out before, in the long term, there's really just a lot that we don't know. And so I think that for women who maybe consider this to be a very short-term aspect, short-term blip, we really had no idea how long this was going to last. It may not have had much impact as it has gone on. Maybe it's something that women have sort of internalized, or maybe it is something that now we're seeing that there's longer term outcomes. In response to what I said to Dana before, at the population level, we still aren't seeing that there's many shifts towards delaying or not wanting any more children. Population level statistics look very similar. But that, that may change over time. But I do think very much culture has a lot to do with it. And I'm going to just put a link to an article in the chat that is sort of a theoretical discussion about how fertility can actually be very much a rational response to increased risk.
Just to add to Linnea's response, number one, I think the beauty of this project is we have another phase of data, and so we will be able to assess longer term effects. But also, there's kind of a discrepancy between some of the narratives in qualitative research and what we're seeing in the quantitative. And I'm thinking specifically of an article that Celia wrote that relates to adolescence and Kenya, where the qualitative is very concerned specifically among adolescents who are experiencing economic insecurity, which leads to partnerships with older men, and partnerships lead to early pregnancy. And this is very prominent in the narratives. And yet when we ask young people if they know of anyone who is in the situation, or the quantitative survey, those situations are rare. However, again, we really need to monitor this situation over time, as we have seen that these economic situations might ultimately lead to the situations that are described in the qualitative. And that's also specifically true for young people who have been out of school for a prolonged time and may not resume school, so particularly for adolescents. And we have just 1 minute, so I am seeing a last comment. One future concern that was noted in the reduced intention and commitment given to SRH efforts worldwide, and this was especially highlighted during the pandemic, with resources being prioritized and allocated to combat COVID. However, it seems that in many low middle income countries, SRH is almost always not prioritized as much as it should be. Advocacy is always a great solution, but would you recommend another effective approach? I think, again, advocacy and research to monitor the situation and show those growing disparities are our best options. And we are on the hour, so I want to thank you all, and especially Linnea, Celia, and Shannon, who have joined me today. Please reach out to PMA website. There's lots of materials, and stay tuned for phase 3. Thank you.